love to. I had a lovely time in Rio.
We are in live now. I'm gonna put the slides on, okay?
Okay, fine.
Can you see the slides? Is everything okay?
Just a minute.
Ah, boa.
Vocês estão vendo os slides?
Sim. Can you see the slides, Professor?
Yes, I can.
Tá inteira a tela, gente? Ok, então...
So I'm talking, who am I talking to? Am I talking to a lovely group of doctors or medical students or what?
Medical students mostly, but we have some doctors watching and nursing students too.
Fantastic, thank you.
Yeah, Lucas is going to introduce the class, then I'll introduce you, and then we can start, okay?
Fantastic.
Boa tarde, pessoal. Eu sou o Lucas, presidente da Liga de Clínica Médica. Queria agradecer a presença de todo mundo aqui hoje. A nossa aula vai ser sobre insuficiência adrenal na emergência. O palestrante vai ser o professor John Ross. Ele é professor na Universidade de Oxford e o atual presidente do grupo de referência clínica para endocrinologia no Reino Unido. Em relação à presença, a gente vai mandar um forms no final da aula e qualquer dúvida vocês podem colocar no chat também, que a gente vai fazer no final da aula.
Yeah. First, I'd like to thank you so much for accepting our invitation, Professor, and for waiting this extra hour. I never thought that summertime would be an issue. And I'm super excited that we were able to make this happen. Adrenal crisis, it's an extremely important matter, and unfortunately, many doctors do not know how to manage it on emergency. So I think it will be really an enriching experience to everyone involved. We have a majority of students, medical students, and I hope they enjoy as much as I will. Feel free to start, to introduce yourself.
Well, thank you. Thank you very much for asking me to talk today. I have a long-standing interest in adrenal disease, and we have a group, as you probably know, of patients who have a special interest in Addison's disease because they have Addison's disease. And I've been trying to help them over many years to develop their own expertise, because if you're a patient with Addison's disease, the best thing is to know all about it and to know what to do when you get into an adrenal crisis. And so that's where I am. I'm a professor of endocrinology in Oxford, and I've been in Oxford for the last year now because we haven't been able to travel. And I just very much hope that everything is okay in Brazil, because I've heard that you're getting lots of COVID cases, and I hope you're all right and managing to avoid the infection.
Yeah,
now,
it's really bad things here, but we can hope that things will get better.
Okay, so you've got some slides here. Do you want me to talk about them, or how do you want me to do it? Or will you talk about it?
Feel free to. No, you talk about it, please. Ele caiu? Oh, meu Deus, senhor.
Calma aí, gente. Eu acho que ele caiu, gente. Só um minuto. Acho que ele já vai voltar. Vamos esperar ele voltar.
Oh, muito fofo, né?
Super solícito.
Sim. Ele esperou uma hora inteira, coitado. Bom.
Voltou aqui. Vou colocar ele novamente, tá, gente?
Can you hear me all right, Judy?
Hi.
Can you hear me?
Yes, we can.
Okay. So will you go through the slides or will I go through the slides?
You go, please.
Okay. That's fantastic.
Okay.
Yes, that's fine.
All right.
So you show me the next slide, please, then. So the adrenal is a gland which you all know is above the kidney, and it's something which is very important, and in fact, it's essential for your life. And this is very important that it makes various hormones, including cortisol, mineralocorticoids, including aldosterone, and then in the middle it makes adrenaline. And those two bits of the adrenal are very separate. And so they work independently of each other. And we'll come on to that in a little bit more time. Okay, next slide, please. So the adrenal gland has three main functions. There's the zona glomerulosa on the outside, the zona fasciculata in the middle, and the zona reticularis in the middle. And then in the absolute middle is the adrenal medulla. And I think that that's important because the zona glomerulosa makes mineralocorticoid, the zona fasciculata makes glucocorticoid and mineralocorticoid, and the medulla makes adrenaline. And those are the important aspects. Now, when you have adrenal insufficiency, the adrenal gland works, but the medulla works perfectly, but the adrenal cortex, which is the outside three layers, don't work so well. And those three layers are ACTH dependent. Can I have the next slide, please? So the renin-angiotensin system, as you can see from this slide, is quite complicated. And the angiotensinogen goes to angiotensin, which goes to angiotensin 2, and that helps to control aldosterone secretion. And this is one of the important aspects of blood pressure control, because blood pressure is maintained by the adrenal. And if you have inadequate adrenal function, then the angiotensin system doesn't work properly, and you can get dilatation of the blood vessels, because cortisol is very important for maintaining the maintaining the arterial tone, and you can get very marked hypotension under low blood pressure. And this is one of the reasons why adrenal crisis, when the adrenals aren't working properly, is so dangerous to a person. Next slide, please. So cortisol is terribly important. It's the main hormone of the adrenal, and it's responsible for maintaining the blood pressure, maintaining inflammatory responses, and doing all sorts of other things which are really important, and without which people actually can die, which is one of the serious aspects of adrenal crisis. Next slide, please. So there are the various layers of the adrenal gland, the glucocorticoids, raising blood glucose levels, stimulating glucose production, the mineralocorticoids, causing distal convoluted tubules, the renal nephron, and regulating uptake of sodium and acid-base balance. And then the sex hormones, which are in the middle, which are quite important, and which also are deficient in people with Addison's disease. And then in the middle, as I've said, the adrenaline and noradrenaline. And these are levels which go up when you're being chased around the field by a bull, or racing up and down Copacabana Beach, being chased by somebody who wants to have something from you which you don't want to give them. Next slide, please. So Addison's disease is very important. It's very rare. And it's caused by deficiency of the adrenal cortex. And primary Addison's disease is something which can be fatal. Often it takes a long time to diagnose. These patients actually are very unwell. They often lose weight. We'll come to their symptoms in a minute. But Addison's disease is a very important disease which is difficult because it is often so very difficult to diagnose because the symptoms are very often vague. They lose appetite, they lose weight, and they often go brown. And there are various things we'll come to in a minute, which actually are very important in terms of how they present. And so often Addison's disease is not thought about because it presents very subtly with symptoms which are not, if you have heart pain, if you have chest pain, it's very easy being a cardiologist because you know it's the heart. But if you have Addison's disease, it's much more difficult because they may have joint pains, they may have a temperature, they may have abnormalities in their blood count, they may be losing weight. But often people don't think of Addison's disease anything like sufficiently earlier, and often it's many years before it's diagnosed. Next slide, please. So stay alert, hyperpigmentation. So most patients with Addison's disease get pigmented. Their skin goes darker. So that if they're white, their face goes browner. They look as if they've been in the sun. And if they are black Africans, they go even darker. And so whatever your skin color, they go darker. And the reason for this is that ACTH is the hormone which comes from the pituitary gland. And in patients with Addison's disease whose adrenals aren't functioning properly, then the ACTH levels go up significantly, and this can cause the skin to go brown. Not everybody goes brown. But most people, 80 to 90% of patients with Addison's disease go brown. And you can see that in this slide on the right-hand side, that hand shows hyperpigmentation, and that's classical of Addison's disease. And I think that's a very important sign. As I say, not everybody goes brown, but it is very, very common if you've got primary Addison's disease for you to go brown. Next slide, please. Secondary Addison's disease is a little simpler in some ways. Secondary Addison's disease refers to Addison's disease because of pituitary problems. The ACTH levels in the pituitary are lower than normal, and that means that the adrenal glands don't work properly. However, there are differences between secondary adrenal insufficiency and primary adrenal insufficiency. In primary adrenal insufficiency, the ACTH levels are high and the patients go brown. But in secondary adrenal insufficiency, they don't go brown. They do not go brown because there is no high ACTH level. However, these patients can often become quite sick. They don't become so sick as patients with primary Addison's disease simply because they actually have usually got retained mineralocorticoid secretion. That means that their aldosterone levels are still reasonable. And that means that they don't become sick, they don't become so hypotensive. And so secondary Addison's disease or secondary adrenal insufficiency is not such a serious condition as primary adrenal insufficiency. Next slide, please. And then tertiary adrenal insufficiency is often drug induced, and there are various drugs which can do this, which include various drugs which metabolize cortisol, like ketoconazole. And then you can occasionally get immune checkpoint inhibitors doing this, which cause adrenal insufficiency as well. And so there are very many causes of adrenal insufficiency. By far the commonest is autoimmune adrenal insufficiency, where the patient produces antibodies to their adrenals, and actually you can measure those in the blood. And I'm afraid that's much commoner in women than it is in men. Next slide, please. And so the pathophysiology is very clear. The glucocorticoid levels are very low. The blood pressure is low. Often there's hypotension when they stand up. and that's partly due to cortisol deficiency and partly due to mineralocorticoid deficiency. And then the DHEA levels, which is the sex hormone, which is made in the middle of the adrenal, are often low, so that patients have a low libido. They may lose their axillary hair and their pubic hair. And what doesn't happen, though, is that their adrenal adrenaline levels are perfectly normal because they come from the adrenal medulla and they're not affected. Thank you. Next slide. There you go. Okay, next slide. So there you get various symptoms of chronic adrenal insufficiency, and I've talked about these. They can become fatigued, they're tired, they're anorexic, they lose weight. 80-90% of people with Addison's disease lose weight. And what's really important is that if you've got a patient who is very overweight and they're feeling tired, you can be fairly sure they haven't got Addison's disease. One of the important aspects of Addison's disease is that they lose significant amounts of weight. They may be nauseated and they may be vomiting. They often have salt craving because that's an important aspect of mineralocorticoid deficiency. And I saw a patient this morning who actually had just been put on fludrocortisone, and he said how amazing it was because his cramps went, his salt craving went, and his blood pressure became much easier. And so they have a number of different symptoms related to mineralocorticoid decrease, including orthostatic hypotension and fever. And biochemically, it's important that they have hyponatremia. Their sodium is low. They may have hyperkalemia, and they may have hypercalcemia. So there are a number of different things, but the most common aspect of their biochemistry is that they are hyponatremic, and that's an important thing. So if you see a patient with hyponatremia, you must make sure that their adrenal glands are working properly, and you should do a synaxin test. Next slide, please. So what is the treatment? Well, we give them glucocorticoids, and there are various types of glucocorticoids. There is hydrocortisone, which is the commonest. Is that available in Brazil, Judy?
Yes.
It is. Okay, so that's fine. So hydrocortisone is the first one. And then they can get
No, Professor. On the pharmacies, I'm sorry to interrupt. On the pharmacies, we do not have hydrocortisone in Brazil. They produce only in São Paulo in one place, so the population does not have access to it. It's really sad. They usually use prednisone. Okay, so prednisolone, the dose is different. So prednisolone, you usually give a small dose in the morning of 2.5, and then another dose in the afternoon of 2.5. And then you can also give dexamethasone. In some countries, they give hydrocortisone, and as you heard from Judy, then they can actually get hydrocortisone. And that's easier because it's possible to measure the cortisol in the blood. But with prednisolone, you can't do that. And then the other thing that's important in primary adrenal insufficiency is fludrocortisone, because that means that their salt cravings go and they feel a lot better with fludrocortisone added in. So that's important. And then sometimes we give, particularly women, because their energy and libidos can be adversely affected, we give them DHEA, which comes from the middle part of the adrenal. So we give them steroids, prednisolone, we give them fludrocortisone, and we give them DHEA. Next slide, please. And so this is important. So what happens to AI patients under stress or infection? Because they can't normally increase. They can't normally increase. Is that your dog or mine? Okay, they can't normally increase their steroid levels, and that's important because they need to have extra steroids when they become unwell. So if you get a temperature as a patient with Addison's disease, or you start being sick, and therefore you're not absorbing your steroids, you can become unwell quite quickly. And that's why it's important to act quite quickly to actually give them replacement therapy.
Next slide, please. So what is an adrenal crisis? An adrenal crisis is a medical emergency where they can become hypotensive and where the symptoms may cause all sorts of symptoms, particularly with the low blood pressure. And they can actually even die if they're not treated quickly. And so they really need to be treated quickly in case their blood pressure goes down. And an adrenal crisis is caused by a number of different things. You can get it when you have food poisoning. You can get it when you have pneumonia. You can get it when you have a heart attack, and you can get it for various different reasons. And the important thing here is that the patients can become sick very quickly. And so they need to go into casualty to the A&E department very quickly, and they need to be given steroids very quickly. Otherwise, they can become hypotensive and get into serious medical trouble. Next slide, please. So adrenal crisis and mortality insufficiency is still a concern, even nowadays, because most people who aren't endocrinologists don't recognize that it's serious, that it needs to be treated quickly. And this is also true with Addison's disease, because if they're not treated quickly, they can die earlier, and that's important. And so even if you have Addison's disease, it's important as a patient to recognize that you can become ill quickly and to get urgent help, both in the A&E department and for your relatives to know exactly what to do. And so that's why we always say in the Brazilian Addison's group and others that the relatives need to know what to do. They need to know how to give an injection of hydrocortisone. And every patient with Addison's disease should have an injection of hydrocortisone to give so that they can be treated urgently in an emergency. And that's very important. Next slide, please. So what happens? So the cortisol is very important, and it's very important that this balance is maintained and you quickly give hydrocortisone. Next slide, please. So what are the precipitating factors? Well, there are lots of different these. You can get gastrointestinal infections. You can get other infections. You can get pneumonia. You can get various other aspects which can cause stress and put the patient at stress. The commonest of these, though, is gastrointestinal infections and vomiting and being sick. And therefore, these patients need to, if they start being sick, there are distinct rules. If they are sick once, they have extra hydrocortisone by mouth. And if they're sick twice, they then need an injection to urgently be given to give themselves safety and not getting into trouble with hypotension. Next slide, please. So what are the clinical features? Well, you can get blood pressure, which is low. You can get abdominal pain, which is a problem. You can get hypotension and fever, abdominal tenderness. You can get hypoglycemia. You can get all sorts of things. These are the features of an adrenal crisis. And again, any of these should be reacted very quickly by the doctors concerned. Next slide, please. And so the next thing is the risk factors. Well, there are various risk factors here, which are important. If the patient with adrenal insufficiency should know what to do in these circumstances, they may need to take extra steroids. They may actually need to have extra thyroxine, but various things which are risk factors really need to be known about by the patients, and they need to increase various aspects of their steroid replacement therapy. Thank you. Next slide, please. So how do we manage emergency-wise the adrenal crisis? And the most important things are to give lots of fluids because their blood pressure is low, and to give lots of steroids, either intravenously or intramuscularly. Next slide, please. And so we give them lots of steroids. We give them fluid resuscitation with saline, and we measure their blood pressure very carefully. And then we also may need to give them dextrose. So saline and fluids are very important. Next slide, please. And then we need to give them extra steroids. And this needs to be given intravenously, so it acts very quickly, or intramuscularly. and we'll give them 100 milligrams of hydrocortisone acutely when they come into casualty or very soon after. We don't give them fludrocortisone so much because if you're giving large amounts of hydrocortisone, then their blood pressure will be all right on extra hydrocortisone, because hydrocortisone does have mineralocorticoid effects. Next slide, please. So in patients with known adrenal insufficiency, treatment should be instituted immediately. That's the important point, within half an hour or so, without delay. And in patients where the diagnosis was not made, they may need to be given steroids, even if they're not clear what the diagnosis is, so that they don't come to serious harm. Once you've done, if you are worried about them having Addison's disease, you measure the cortisol and the ACTH. And if the cortisol is low and the ACTH is high, that means that they've got Addison's disease, and then you're clear about the diagnosis. If there's any doubt, you'll go on and do a synaxin test. But if the cortisol is very low and the ACTH is high, that means that that's what the diagnosis is, and they need long-term steroids. Next slide, please. And so how do we prevent adrenal crisis? Well, we've got to be very careful that we take the steroids regularly. We need to make sure that the patient is properly educated, that the patient has his or her relatives educated, and that they know how to take hydrocortisone in an emergency, and that they know to be clear to get some help if they need extra help. Next slide, please. So this is important, how to educate the patients. They need to know what the signs of adrenal insufficiency are, what the signs of an adrenal crisis are, and their relatives also need to know. And there's a very good charity in Brazil, isn't there, Judy, which actually helps to educate patients with Addison's disease, so they know what the early signs of a crisis are, and they also know what is going on in terms of their blood pressure and things. And so you need to know about it as the patient, and the patient's family needs to know about it. The nearest relatives need to know about it and need to know how to do it in terms of an emergency. Next slide, please. And so we have this card which we've developed, and I don't know whether you've got it. I think you've got it in Brazil, but you should carry this card if you've got a patient with adrenal insufficiency. Patients with Addison's disease should be given one so that the people can see that they've got Addison's disease and actually make sure that they get treatment and that it's recognized quickly. Next slide, please. So this is how to do it in the future, because I think there are new types of glucocorticoid replacement therapy being developed, which actually are very longer lasting. And this is something which is possible because hydrocortisone lasts for a few hours, but you don't normally use that in Brazil. But prednisolone works and lasts a little bit longer, so you only need to give it twice a day. There are some steroids, though, that actually can be given once or twice a day, and that is probably the thoughts for the future. And this particular steroid is called Plenadrin, which I think is also quite important that you know about that it's coming. Unfortunately, it's much more expensive, but it is coming. Next slide, please. And so here we are, a long way away from Brazil, but it's lovely to talk to you and to talk about it. And if you want, we could spend some time answering some questions about Addison's disease that you might have. And Judy, thank you for asking me to talk. I hope it's been okay. There are some references for you, but I hope you've understood what I've said. And I'm sorry, my Portuguese is not very good, but it's been very nice to come over and hear you. And Judy, thank you very much indeed for asking me.
Thanks so much for coming, Professor. It was an honor. I'm super grateful that you're here, and it's a really important matter. I have a personal question about modified released cortisone. What do you think? If it's going to be a reality?
Okay, so that's a very good question, Judy. And I think it's something which might well become important in the near future. Most of the time, giving prednisolone is enough, and most of the time that requires no extra doses. And so modified release is sometimes the case when you've got people who may not be absorbing it for various reasons. But to be honest with you, number one, it's much more expensive. And number two, it's not often necessary if you're giving prednisolone or hydrocortisone. That's a very important question, and I think it'll come soon.
Thanks. When I was reading the articles, I found a lot about this new medication, and I've never heard on the university. So,
well, I think
nice
it hasn't. So I think it's fair to say that it's much more expensive than the ordinary prednisolone, and that's why it's more difficult. It's more difficult.
Nice, Professor. Thank you so much for coming. It was an honor. When I wrote you the email, I didn't even think you were going to correspond, so I was really excited that you were able to. Are you
going to be an endocrinologist? Are you a doctor?
Yeah, I think so. Maybe I'm in neurology or endocrinology. I love them both.
Well, the advantage of endocrinology, Judy, is that you can make people better. And with neurology, you can't make them better so easily. And so as an endocrinologist, if you give a hydrocortisone to somebody who's got Addison's disease, literally in 1 hour, they will feel better. And they'll be very grateful, and you'll change the whole of their life. If you have neurological disease, you can't so easily get them better. So I'd very much encourage you to be an endocrinologist. The world needs lovely people like you to be endocrinologists. And Brazil in particular, and also in Brazil, there are some wonderful endocrinologists in Sao Paulo and in Rio, who I know and actually think are wonderful people.
Yes, Professor. Thanks so much. I hope we can meet in person one day when this all passes.
Well, the next thing you must do is to come to the American Endocrine Society.
Yes, one day soon, I think. I hope.
Yeah, I hope too. Good.
Thanks so much again for waiting this extra hour. I hope you have a lovely evening and summer. And do you want to say something, Lucas?
Thank you, Professor.
Well, it's very nice to be there, and I'm sorry I'm
not there
because I want you to know that I've had some lovely times in Brazil. A few years ago, I organized the big international endocrine meeting in Rio, and I had to come over to see that it was a nice place, and then I came over for the meeting itself. And I've been over to Brazil a couple of other times, and it is the most lovely country. And you know how to have a good time in Brazil. You know how to have a good party. You know how to have a good and enjoyable time and enjoy yourselves. And I think it's a lovely country full of the most lovely people. And I hope that the COVID business, you all get over very quickly, because it is a lovely country and I'm longing to come back. And if you ever want to come to England, Judy or Lucas, then let us know and we can fix it up for you to come and visit one of our departments.
Perfect, Professor. Thanks so much. When you come to Brazil, we can go to the beach and have a really good time when this all passes. And thanks again for having us.
Well, it's a pleasure. I hope that was helpful, and it was very nice to meet you. Bye-bye.
Nice to meet you too. Have a great night.
Bye-bye.
Bye. Bye. Bye.
Tchau, gente. Muito obrigada pela aula.